lipid disorders, traditionally, we have been considering more in terms of the genetic causes, which are very, very rare, but which can have a lethal consequences in that regard. But now we are seeing much more common in terms of the lipid disorders in terms of obesity and complications. Lipid cycle is constituting of the intestine from which the lipids are absorbed. From there, they go to their target areas where they are used, as you said, for the cardiac function and the muscle function, where you have fatty acids, ketones, and all those things are being utilized. Now, from there, they can go to the organs which are producing steroids like adrenals and then get deposited. From here, the lipid also goes to the liver. Now, liver plays a very, very central role in that regard. Liver is not only the cause of lipid disorders, it is also affected by lipid disorders. Now, all your studies about steatohepatitis is about that. So, lipid, ultimately, liver will have to manage. That's its responsibility. So, if you are not able to manage liver lipid properly, ultimately will have a problem in terms of hepatic function as well. So, liver is both a player as well as somebody which has got affected. Now, liver will be able to metabolize these lipids and then send it back to the circulation, where again excess lipid will get deposited in the macrophages, and there it will go into the vasculature, and that is going to cause all the complications. So there are good parts of lipid action in the muscle, in the heart, in the adrenals. Bad part is mainly the deposition, which causes harm in that regards. Now, when we talk about lipids, we talk about a few things. We talk about lipoproteins, we talk about apolipoproteins, enzymes, and transporters. And these all four will then combine to produce the whole lipid cycle. So what really is a lipoprotein, Dr. Vibha?
Lipids and the protein. Lipids are basically this cholesterol and the triglycerides and the proteins, and this is the apolipoprotein.
So basically you have got a lipid and protein in a sort of a shell. So it's like a package. It's like when you see you have got all the oil which has been imported and now it's been sent in those big vehicles. You see all those vehicles which carry the oil in which, so it's like a vector. So it's like you have sex hormone binding globulin, you have got other thing which is carrying testosterone. Similarly, this is a lipid carrying large vehicle you can think of. So it has got proteins also, and it has of course got within it, it has got an emulsification, there it has got cholesterol and lipids. Now, what is apolipoprotein and what role do they do?
Apolipoprotein is which basically determines the distribution of the cholesterol and triglycerides, where they have to use from where they have to metabolize.
So apolipoprotein basically is controlling the overall effect of that cholesterol, where to release, where to metabolize, where to go. So it's one of the most important part of the lipoprotein complex. Then there are multiple enzymes and transporters which regulate the overall process. You have got lipase, which are mainly releasing the fatty acids. They are acting mainly on the triglyceride and chylomicron. So lipoprotein lipase and hepatic lipase. What else?
Apart from that, we have various transporters and which is responsible for the
and there is also a acyl transferase, which is very, very important, and you have one which causes sulfation. So sulfated products become also important. So in a way, if you talk about this, lipoprotein itself has got lipids and proteins, which is apolipoprotein, and enzyme and transporters. These three will decide your fate. We'll go one by one. So when I talk about lipoprotein, as Dr. Vibha said, you've got triglyceride, you have got cholesterol esters. So you need to esterify the process, and you have got native cholesterol as well. So it's like a mixed bag. In the same truck, you are supplying all these things together. And very importantly, how would one part differ from the other would mainly be, as Dr. Manoj said, the apolipoprotein. So which apolipoprotein is there, which direct it, which organ will it work, where it will release, how much will it release, when it will be uptaken from that perspective. So the first one which I'm going to talk about is chylomicron, which is basically the exogenous source. It is the imported lipids which body has. This comes from the diet. So chylomicron is unique that it has got huge amount of triglyceride. It has got less amount of cholesterol. It has got largely triglycerides in this scenario. It comes from the intestine and it is the carrier of dietary lipids. It has got multiple apolipoproteins. We talked about B, So apolipoproteins are designated into different forms A, B, C. B is important. What does B signify? If a lipoprotein has ApoB, what does it mean? Dr. Vibha?
So B100 is for LDL.
No. What does it mean? So if we say ApoB containing lipoproteins, they have a specific character.
This is basically for
They are all
They have to get the triglyceride in the body.
atherogenic. So all the ones which contain ApoB, LDL, VLDL, all that will usually be atherogenic. This one also has cholesterol, that is why, but mainly other ones, the ApoB 100 ones are even more atherogenic than ApoB 48. So this B48 will decide where they will go from that perspective. Now, ApoC2 is very important. It actually activates the lipoprotein lipase, and there is another ApoC3 which will inhibit that from that perspective. Now, this lipoprotein lipase will then digest the triglyceride. So it's like this truck is now carrying the overall process and it is going from a different scenarios. Now what happens is that they are being taken to different stores, and from there the triglyceride has been taken off, the oil has been taken off, and that is the way it is progressing from that perspective. Now, C3 is an inhibitor of lipoprotein lipase. So what will be the causes of which defect C2 or C3 will cause high levels of triglyceride? If we talk about lipid source, it is coming either from the intestine or from the liver. Now, sterol or cholesterol ester are taken in by the intestine, and largely triglyceride is absorbed. That is why chylomicron has got 95% of triglyceride, only 5% of cholesterol. Now, from there it goes to the periphery, and the liver is producing its own version of lipid through the HMG-CoA, which is basically for the cholesterol production in that regards. Now, intestine, we know that there is a sterol and cholesterol esters which are there along with triglyceride. They are then converted into glycerol, fatty acid, and sterols. So sterols are the plant sources and cholesterol is the animal source. So both are there, but ultimately they have to be broken up from that perspective. Now these are then formed into a emulsion and a micelle. What is a micelle?
So it is a water covering over the liquid.
So water? So it's like a liquid carrier. It's like a big droplet. So you have put like thyroglobulin. I'm not talking about that's equivalent, but thyroglobulin is like an area in which everything is going on. So you form like a big fish net in which you have collected all that, and then it will drag together in that regards. And then from there, it is going to be absorbed and then goes to the lacteal in that scenario. So intestinal absorption of lipid is both an active as well as a passive process. So lipid can directly come in via micelle in a passive formation, or fatty acid and cholesterol come through specific transporters like CD36. And then there is a very, very important protein, which is the mitochondrial protein, MTP, which will then package all of them together. So fatty acid, cholesterol, and triglyceride, all of them will get deposited here to form what is known basically here as a chylomicron. And this chylomicron will then go into the lacteal, and from there it will go into the circulation. So if you have a problem in the lymphatic system, can you have high triglyceride because of that?
No.
Any particular condition which can cause this? So if there is a surgical problem in the thoracic duct, then what is going to happen is that there will be a lot of leakage. Lymph has got a lot of this triglyceride. This is then going to cause a hyperlipidemia, hypertriglyceridemia, which you need to be aware about in that regards. Now this cholesterol from here, approximately 50% will then be reabsorbed in that scenario through this again, the ATP binding cassets, which are important. Now sterol is a plant source, and if you take sterol, it comes via the SRB1 receptor and the Niemann-Pick receptor. It comes into the circulation, but 95% of it is absorbed, 90 to 95%. So if you take more of plant sterol, will it be beneficial or will it be bad?
It will be beneficial because it is complete with the cholesterol absorption. So more amount of fat will be absorbed. So this cholesterol is absorbed.
And this plant one will go out. So 90% will go out. So if you take more of sterol, you will have a very good scenario in which your actual cholesterol absorption will become less. But if you have a problem in these ATP binding cassettes, what will happen? So you will have cetosterolemia, in which you will have got more amount of sterols which are there. So this is an important factor to worry about in that scenario. So this absorption is crucial in that regards. So dietary lipid pathway, as I said, triglyceride comes, it's packaged into the chylomicron. It then goes to the lipoprotein lipase site in the various blood vessels. And from there, ApoC2 will activate this lipoprotein lipase. ApoC3 will have an inhibitory effect on ApoC2, and triglyceride is released, goes to the heart, goes to other areas as well. Now from there, this gets deposited and is used, and then the amount of triglyceride will be less in this chylomicron. It will then go to the liver, and remnant receptor will take it up. So basically all the remaining protein will again be utilized again to produce a new package in that regards. So chylomicron metabolism, we know lipoprotein lipase will convert it into basically IDL first, and this happens largely in muscle and fat. Why in muscle? To provide immediate source of energy. Why in fat? To provide triglyceride for storage. That is how it will work. And this metabolism will basically cause a loss of triglyceride. When your triglyceride loss is very significant, it will lose C2 and C3. So now you cannot take any more triglyceride, and then it will get converted into what is known as IDL in that scenario, and then remnant receptor will take it up. From that perspective, hepatic lipase will work. So hepatic lipid production discussed, it involves a lipoprotein, carbohydrate and fatty acid, and triglyceride, again MTP, the same one comes here. So if you have a MTP problem, Dr. Manoj, what is going to happen?
This different packaging will be not there. So we have lots of amount of the triglyceride, and it can cause a antigen.
In this case, the both will be affected. Liver also is not able to be able to take, and even in circulating is not going to enter it.
So you will actually have deficiency of these things because it needs to be packaged into this. So you will effectively have no VLDL, and you're not going to take it at all from the intestine. So because intestine packaging is important, otherwise it will be lost in the stool pretty much. So you will have a lot of fat soluble vitamin deficiencies will be there, and it will be more like a steatoria like picture. So that's a very important scenario. We don't hear it often because it's not an endocrine parameter from that perspective. So ApoB100 is then packaged, and then triglyceride comes, and there the VLDL will come from that perspective. It goes into the lacteal, and then it goes into circulation. Why does VLDL, LDL, all those go through lacteals? Why do they use lymph, not the blood? So because the target areas of triglyceride are easily accessible initially from the lacteals. The cholesterol areas are more towards the blood. That is why you use that in that perspective. So lymph is local. Very quickly you go to the muscle and other areas as well in that regards. And then you acquire C2 and C3, which will then play an important role in modulating the action of lipoprotein lipase. C2 increases, C3 inhibits that. So this is the process from that regards. Now VLDL, like chylomicron was converted into chylomicron remnant, which went into the liver. It is converted into IDL, which is an intermediary form. Again, C2, C3 is lost, and you've got the IDL, which again is taken up by the remnant receptor. Now this IDL, again, as I discussed, all your triglyceride grows and you become a pure cholesterol transfer, which basically be in the form of LDL, which is there, and LDL is taken up through the LDL receptor and adapter protein, which we discussed subsequently from the liver. Now, this is very, very important from a pharmacological perspective. So LDL uptake, we know that LDL is basically containing mainly cholesterol and various apoproteins. It is then going to act via the LDL receptor and the adapter protein. It comes inside the cell. Now, the next process is to release that. So to release that, you will need, there is also a micelle sort of a thing which is formed, like a protective barrier, so to speak, that is the micelle. Now, using the acidification process, this protective barrier is broken. And now you have got cholesterol, pure cholesterol. So what you have done is that you've destroyed it and the inside content you are starting to use. And this cholesterol is going to be there, cholesterol, fatty acid, and all those things will come into the picture. And you also will be using those amino acids. So again, you will use it again to produce more apoproteins from that perspective. Now, what about this LDL receptor? This LDL receptor will again go back. So like we know all the MC4 receptor, MC2 receptor, you don't produce so many receptors. Its work is not for a single one. It is going to work multiple. So recycling of this receptor happens. But this recycling can actually be destroyed via a very, very specific compound or enzyme, which is PCSK9 or protein convertase subtilizing type 9. So this is a group type of enzyme which degrades LDL receptor. Now, Sayan, can you tell me which conditions can cause high cholesterol in the blood based upon this slide?
Absence of LDL receptor.
So there is no LDL receptor, number one. Second, so PCSK9 is working more. That's fine. What else? So if you remember of familial glucocorticoid deficiency, type 1 is because of, type 2 is because of, so you've got something like MRAP here. So adapter protein defect is also going to cause hypertriglyceridemia, hypercholesterolemia. Now, based upon this, can you think of a pharmacological agent which can be used to reduce hypercholesterolemia? PCSK9. So if you inhibit that, you will have more LDL receptor. So as I said, if you have got more AVP receptor, if you have got more epithelial sodium chloride channel, you got more aquaporin on top, you will get more water, more sodium coming in. So more LDL receptor, more LDL will come into the system. So if you increase the LDL receptor via inhibiting PCSK9, you will be having a good way of controlling hypercholesterolemia. That basically is a mechanism for very refractory form. We use PCSK9 inhibitors. Now, the other mechanism is that if your cholesterol synthesis is less, what will the cell do? Cell needs cholesterol. Now, suppose our country has reduced production of oil. What will we do?
Cholesterol production will be there, then it will take more uptake. It will uptake more cholesterol into the cell. So ultimately, our cholesterol from the outside will be this.
So we will be taking in cholesterol from outside. So if you inhibit this HMG-CoA, essentially what will happen, your LDL receptor will be more. It is trying to get your cholesterol inside. So inhibitors of HMG-CoA will also help out, not only by reducing the synthesis. Some people will say, okay, it reduces the synthesis of cholesterol. No, that is not the major mechanism. The major mechanism is if you inhibit HMG-CoA, LDL receptor goes up. It is going to take a lot of LDL from the blood, and that is how it is going to help out. So this is also working through that mechanism. So endogenous lipid pathway is largely VLDL, which is produced via the liver with around 80% triglyceride going to the circulation, releasing the triglyceride there, using the again lipoprotein lipase system, becoming rich in cholesterol, converting into IDL, which then converts into LDL, and this LDL is again taken up by the liver. So it's like a complete cycle which is there. Of course, all this VLDL, ILDL remnants will also be taken up by the liver in that regards. And this LDL, if you have too much and liver cannot take it. Now, that's the important thing. If you have got too much LDL and liver cannot take it, it has to go to the circulation. It will go back to the blood. It's like overflow, overspill. So if you want to reduce your level of atherogenesis, you either reduce the level of cholesterol or you increase LDL receptor. That's pretty much it. You can't otherwise manage it in that regards. So LDL will basically have deposition in the macrophages, and this is going to cause atherosclerosis in that regards. VLDL, IDL, they will all be taken up by the different receptors in that scenario and hepatic lipase. So till now we have talked about the atherogenic lipoproteins. What about the HDL pathway? So again, it starts from the liver and ends to the liver. Now, what does ultimately the HDL pathway do, Sayan?
It collects the bad cholesterol and deposits it.
So it collects the cholesterol, we can't say good or bad, from the periphery to the liver. LDL is taking cholesterol from the liver to the periphery. HDL is taking cholesterol from the periphery back to the liver. So HDL again is produced in the liver and then it goes to the circulation. As discussed, it has got a very important cassette transporter in which it says, okay, give me your excess amount of cholesterol that you've stored there. It then has other mechanisms to esterify the LCAT, which we discussed. And then it also has a way through CETP to take up the cholesterol from that perspective. An exchange will happen in that scenario, and then it will become the cholesterol is going to work in that scenario. And this will again, the HDL2 will go up and the liver will take it up. It will have specific proteins to assess that, take up the cholesterol and convert it into HDL. So there's a whole cycle, like water cycle we talk about. There is a HDL cycle, which in a nutshell takes off cholesterol from the blood vessel back to the liver. This is the main mechanism of reducing the peripheral level of HDL. So what we said, if you want to reduce your blood cholesterol, eat less amount of lipids, or you have got more amount of HDL, or you increase the LDL receptor. These are the three mechanisms which are basically there in that scenario, and this HDL then works from there. So whatever I've talked over the last 50 minutes or so, just to summarize that, and this will be the nutshell, probably we'll close at that point of time. Whatever lipids you take is uptaken both via a passive and an active mechanism via the intestine, packaged into chylomicron via MTP. And this chylomicron will then become a big supplier of triglyceride in the periphery. And this process requires lipoprotein lipase, C2, and GP1, HBP1. Now, I'm talking about only those which are relevant from a disease perspective. So all of them will cause certain diseases. Now, this triglyceride is then used by the circulation. It is used by the adipocyte, and then it is converted into a chylomicron remnant, which is taken up by the liver in that scenario. Now, liver is going to package its own lipid, which is produced here via MTP again into VLDL, which has got 80% of triglyceride and 20% of this, which goes again in the circulation as a source of triglyceride and cholesterol. Excess amount of cholesterol is going to get deposited within the lumen and cause a problem. HDL is going to take up this excess amount, and via LCAT and CTP, there is an exchange process and again taken up via the liver per se. So this is a mechanism of bringing it back from there. LDL is taken up via the LDL receptor in that scenario. So now, Naveen, out of these, which are the known causes of lipid abnormality? If you can just label one by one. Maybe low, high, whatever you want to say.
So in case from C2, which can result in hypertriglyceridemia, and apart from the lipoprotein lipase, and also there's a difference in GP1, HBP1 protein.
So C2, LPL, GP1, HBP1 will cause hypertriglyceridemia. Then?
And next, when we come to the CTP or the LCAT pathway, it basically causes the accumulation of cholesterol in the body.
So HDL problem, EPO problem will cause a problem in terms of periphery cholesterol will be more, and you will have yellow tonsils in that regards.
And the more classical the LDL problem is the problem, which results in familial hypercholesterolemia.
So LDL receptor defects will cause familial hypercholesterolemia. The most severe forms are there. MTP defect. So you cannot absorb any of this, and your blood is totally deficient in all that. So that will be a vitamin D, vitamin deficiencies from that perspective, and that becomes relevant. And of course, PCSK9 will also cause this problem. Now, finally, why are we talking about all this? We are talking about all this because of complications which happen, and particularly the atherogenic complications. So we all know that if you have too much amount of cholesterol, it goes into the macrophages, and these macrophages will get then deposited in the blood vessel and form a atheroma. Now, atheroma will start off not as a lesion, but just as a streak. So people have seen, there was a very interesting Bolegusa heart study in which they studied the autopsies of young people who died. And they just did autopsies of those people in accidents or something. And they found that streaks are formed very early in life. So all these problems start very early in life. So fatty streaks, which then develop into atheromas and then they rupture. The problem happens is when they rupture and they embolize. So one is that you have got blocked arteries already. And then if you have an embolization from there, it's a complete blockage.